on IOL power calculation in challenging situations. Please keep your questions for the end. You can note down, otherwise you will forget.
Good morning, everybody. IOL power calculation in the different situations. The goal of surgery has been changed from the good visual outcome. It has been shifted to the accurate calculation of IOL power and the good refractive outcome. In the current practice, as a regular cases, the gold standard chart we are using in our normal routine patients, third generation formulas, ULAD1, Offer-Q and SRK in our normal eyes from normal to short to long eyes. But the fourth generation formula is most essential for the calculations of the extreme long eye or extreme short eyes. So this is for the formulas which we are using for the normal patients. But what about the patients who have a special situations, the patients who have undergone the refractive surgery before, or a patient who have to operate a penetrating keratoplasty along with, or may have operated keratoplasty before, a patient who have undergone the vitrectomy surgery, or patient who have already silicone filled eyes. Very short eyes, you may require more than one lenses in the eye, or very long eyes, or keratoconus patients. So all these special situations we have to attend differently. Just we will go one by one for this. The post-refractive surgery, the most important consideration is the IOL selection, IOL power consideration, calculations. These two will be our talk. The IOL selection, a patient who have undergone the surgery, RK or PRK or a LASIK, they have induced some higher order aberrations and some degree of corneal irregularity. So all these patients has to be evaluated on the topography and aberrometry, as the Dr. Ramesh Durarajan has been already told in the first talk. A patient who have been undergone the refractive surgery before 15-20 years, so they have always a spectacle-free vision for the future life also. So they will ask for the multifocal lenses. Should we go for multifocal in these patients or not? A patient who have been operated for the low or early moderate myopic LASIK may have less higher order aberrations. Do a topography. If you have a good corneal topography and good aberrometry, you can go for multifocal in these lenses. But a patient who have more than 8 RK cuts or a moderate to high LASIK correction, they have bad corneas, they have very higher order aberrations, and avoid the multifocal in such patients. Aspheric lenses are commonly used in the practice. Should we go for aspheric lenses or not? A patient of a RK more than 8 cuts or myopic LASIK, they have always induced a positive aspheric cornea. A patient should be evaluated for the asphericity, and according to the positive asphericity, you have to select the lens for the negative aspheric lenses. But patients who have been undergone the hyperopic LASIK or piece-by LASIK or very aggressively treated LASIK for more than 8 diopter, in such patients the asphericity is also variable, so it's better to keep a zero aspheric lens rather than putting in negative aspheric lenses. Toric IOL, should we go for Toric IOL? Yes, we can go for it if the topographic finding is good. There is no corneal irregularities, you can plan for the Toric IOL in such cases. But patients who have undergone the RK or hyperopic LASIK, it's better to avoid or be careful when you are putting a Toric IOL in such patients. Refractive goal, usually the surprise of post-op hyperopia, so rather than keeping a emetropia as a target, keep a minus 0.5 or minus 0.75 as a refractive goal in such cases. Why we need a different IOL power calculations formulas? Because in a conventional formula, the effective lens position is the main consideration in the third generation formula, and the refractive surgery makes a change in the asphericity of the cornea. There is change in the relationship between the anterior and posterior curvature of the cornea. There is change in the refractive index of the cornea. So all these factors are responsible for the effective lens position. So we are getting the erroneous results in our conventional formula. What we should do? So many formulas are there. There is no magic bullet formula that you use this formula and you will have emetropia. So you have to use the Higgs-L formula on IOL Master, or Holaday 2 online, or Barrett 2K formula online. Use ASCRS online calculator, and if you have access to all of them, make a combination and try to afford to make maximum out of them. This is the ASCRS online calculator. Fill all the data which is available along with you, and according to that will be give the readings of the Sama's method or the Higgs-L method or whatever the available methods according to your data you have put inside. A patient who have undergone refractive surgery may have the prior records also that he has a previous keratometry was this and he has corrected for the -4 or -5. If this all data is available, then the newer Barrett 2K formulas works very well. That is available on APS series website. If you do not have any accessibility, there is double K correction method. That is by Embroidery. Double K correction method in the conjunction with SRKT or FRQ or Eulade, one according to the actual length of the patient, you can use for that also. A patient who has undergone the RK, the diurnal fluctuation of keratometry is very much troublesome in RK patients. So in our cases, we usually ask patient to come 2 or 3 times and just assess the keratometry in the morning time, in the evening time, and then find out which is the best keratometry for them. And so it's better to have a pentacam readings. That is a most reliable one for the post-RK patients. Another option for the post-RK is a 2-stage modality. First, you do a simple cataract, do a refraction on the very next day, and according to spectacle versions formula, put IOL in those patients. It works very well in our hands. Another situation is the post-vitrectomized. Now, important thing is whether the eye is with silicone oil or not. If it is not silicone oil, consider as a normal eye, and all the regular power calculation formula can be used for that. But the eyes with the silicone oil, the two important consideration, what is the actual length of the patient and how much IOL power has to be modified, and modest selection of the IOL is very important in such cases. A silicone filled eye with a no mature cataract or not advanced cataract, optical biometry gives the best results. Or eyes with the gas which blocks the ultrasound, so only option is optical biometry if the gas is there. When the silicone filled eyes, variable density of the silicone eye is responsible for the dampening of your ultrasound, and that will create a problem. So usually we all have an ultrasound with the silicone oil mode. So you put in the silicone oil mode, and that works very well. If you do not have the ultrasound which has a silicone mode, you just calculate by 0.75 multiplication with the Axl length which you are measuring. Another important thing is whether the eye is fully filled with the silicone or partially filled with the silicone oil. If it is incomplete filled with the silicone oil, in the supine position, the silicone oil will rest on the retina and the fluid will be rest in front of the silicone oil. So this gives the error in the results. So better to take a supine position reading when the partially filled silicone oil is there. Even though some patients, it's very difficult to measure the Axl length in such patients. So it's better a patient who is doing the surgery for the retina or vitreous surgery, they should do a first Axl length measurement, because majority of these patients have undergone cataract surgery within very near future. So better to have optical biometry before that. Silicone oil removal and then do a cataract surgery, that is also one of the better option. Use the fellow eye is also one of the good options. CT scan image, and last option, put a standard IOL. Now this silicone oil works as a minus lenses. So whatever you do, there is always a chance of hyperopic overcorrections. So you have to make some adjustment for that. The rule of thumb, if you are using the plano-convex lenses, then add the 3 in the calculator power. If you are using the biconvex lens, add 5. And tell the patient when we are removing the silicone oil, there is always a 2 to 5 diopter induced myopia after the surgery, or removal of the silicone oil. So these are the important considerations. Very long eye, posterior staphyloma. If more than Axl length is more than 26, there are high chances. And more than 33 millimeter Axl length, the 70% of the chances of staphyloma. So better do a optical biometry in such cases, that gives the best results in such cases. Non-availability of the biometry, AB scan is, vector AB scan works very well. And corneal transplantations, the calculating, 1 minute. Corneal transplant calculations, presently no method at present. So optimal method is do a keratoplasty along with the cataract removal, leave aphakia for 3 months, and stabilize the eye and the calculate power with the spectacle versus followed after 3 months, and put IOL implant secondarily. The keratoconus and cataract, this is very important thing. SRK2 works better in the keratoconus patient, and the SRK2 is worst in the keratoconus patient. So you have to be careful when you are selecting the formula for the keratoconus patients. And another important thing is the IOL selection. Monofocal is always preferable, never the multifocal. Toric IOL can be done, but only for the patient who have a non-progressive with some regularities in the astigmatism, and most important, non-RGB cases. Non-RGB cases, because the patient who have already on the RGB lenses, they are very difficult to have a good toric IOL implantation results. So we have to be careful when the patient is dependent on the RGB lenses not to put the toric IOL. In very short eyes, the primary pseudophotography, calculate the IOL power with the maximum available IOL power. You need 2 implants in the eye, and preferred approach is place the 2 IOLs of different material in different locations. A low power thin convex lens in the silicone lens in the sulcus, and the high power acrylic lens in the capsule.